All right. Well, keeping along the lines, we've been doing some cardiovascular disease review, and this is going to, hopefully we can get through most of this lecture. If not, we'll finish it up next time and do a little bit more. Just a quick fact, on average, a heart beats about 70 times a minute. That's 4,200 times an hour, 100,000 beats per day, 365 million beats per year, 30 billion beats in an average lifetime of 80 years. The adult heart pumps about 7,500 liters of blood daily, and it takes 20 seconds to pump blood to every cell in your body. Cardiovascular disease is the #1 cause of death in the United States, and many times the first indication of this disease is an acute coronary event. Cardiac arrest is the most severe manifestation of acute coronary syndrome, and with rapid intervention, EMTs can make difference between life and death. Cardiovascular disease claims over 1 million lives per year, and cardiovascular disease is the leading cause of death in America since 1900. Sudden cardiac death accounts for about 40% of these deaths, and the majority of our 911 responses are for chest pain. Controllable risk factors, those things that we can control: smoking, high blood pressure, elevated cholesterol levels, and elevated blood glucose levels, diet, lack of exercise, and stress being probably the hardest for most of us to control. Uncontrollable risk factors: age. Every day we get older. You can pick your friends, but you can't pick your family, so family history. Race and sex, male being ahead of female as far as uncontrollable risk factors for heart disease. This is a basic anatomy of the heart. You can see that it's got 4 major chambers: left atrium, right ventricle, and left ventricle. And we'll go over 2 aspects of the anatomy in just a moment. So we're going to go with this little vignette, and you can watch it as it goes. The heart beats top to bottom, atria, then ventricles, sending oxygenated blood to the body and deoxygenated blood to the lungs through one-way valves. The low pressure side is coming out of the left atrium, and it goes to the lungs to be oxygenated. The high pressure side, of course, is the aorta, where it goes down to the smaller vessels and capillaries, eventually returning to the heart on the lowest pressure side, which is through the right atrium and ventricle. Red blood cells carry oxygen to tissues and cells, and they remove CO2 and waste. White blood cells fight infection, platelets, and they help to clot the blood. The electrical system of the heart, we've talked about in detail before. It starts with the sinoatrial node, and you've got your internodal tracts to the AV node. The AV node then goes through the right and left bundle branches to conduction pathways to the ventricle.
The heart generates pressure gradients that drive blood flow through the vascular system. Although the heart appears to be a single structure, it is divided by a central septum into 2 separate pumps, each consisting of 2 chambers, the atrium and the ventricle, that alternately contract and empty during systole, then relax and fill during diastole. The timing of the electrical and mechanical events in these chambers must be precisely controlled to ensure efficient cardiac function. The timing of atrial and ventricular contractions relies on two primary cell types: cardiac myocytes, which do the mechanical pumping, and autorhythmic cells, which initiate and conduct electrical impulses that drive contractile activity. Autorhythmic cells cyclically depolarize on their own, then fire an action potential each time they reach threshold, a process known as pacemaker activity. This activity originates from primary pacemaker cells in the sinoatrial or SA node in the upper right atrial wall. The pacemaker potentials swiftly move through the interatrial pathway to the left atrium and spread throughout the atrial myocardium via gap junctions. As a result, both atria depolarize and contract as a single unit. The impulses generated by the SA node also rapidly spread through the internodal pathway to the atrioventricular or AV node at the base of the right atrium. The AV node is the only point of electrical contact between the atria and ventricles. Here, the impulses briefly slow, allowing the atria to contract and empty their contents into the ventricle before ventricular depolarization and contraction occur. The impulse travels quickly through the bundle of His within the interventricular septum. The bundle branches into smaller Purkinje fibers that radiate throughout the ventricular myocardium. Action potentials travel quickly through the Purkinje fibers, then spread to the surrounding ventricular myocytes via gap junctions. Depolarization triggers contraction. Repolarization triggers relaxation. The swift spread of the impulse through the specialized conduction system ensures that the ventricles become excited and contract as a unit. The spread of cardiac electrical activity may be recorded using electrodes placed on the body's surface. The recording, called the electrocardiogram or ECG, has several distinct components. The P wave corresponds to atrial depolarization. The QRS complex appears with ventricular depolarization. The T wave represents ventricular repolarization. The P wave initiates atrial contraction, which completes ventricular filling. The QRS complex initiates ventricular contraction, which pumps blood out of the heart. During this time, the atria repolarize and relax. The T wave initiates ventricular relaxation, during which the ventricles fill once again. One cardiac cycle is complete.
Okay, so the heart is supplied by coronary arteries. The major coronary arteries are the right coronary artery, left main coronary, and the left circumflex, left anterior descending, and the posterior descending arteries. These are the ones that are majorly affected during STEMI or MI. And you can see that they all branch directly off the aorta. Cardiovascular disease patients with established coronary artery disease have a high risk of cardiovascular events, including myocardial infarction, stroke, and death from cardiovascular disease. Therapeutic lifestyle changes in the form of increased physical activity, dietary modification, weight loss, and smoking cessation are of proven benefit and may improve outcomes as quickly as 6 months. Drug therapies of proven benefit include aspirin, statins to lower cholesterol, and in patients with MI or heart failure, beta blockers and angiotensin converting enzyme inhibitors, or ARBs, angiotensin receptor blockers. These therapies work in part by ameliorating the risk attributable to the major modifiable risk factors of hypertension, increased dyslipidemia, diabetes, and smoking. When we talk about the heart, we talk about cardiac output, which is a simple formula of stroke volume times heart rate. Either parameter can increase or decrease cardiac output, and it varies with activity, and other factors. Blood pressure is measured in every patient greater than 3 years old, and it is the pressure exerted on the walls of the arteries. Cardiac output times the resistance of the vessels is the formula for blood pressure. So contributing factors are the force of contraction, the heart rate, how fast it is going, the status of the blood vessels, whether they are dilated or constricted, and the blood volume. Inadequate circulation is known as shock, and shock is another way to say hypoperfusion. Signs we have talked about in the past are cyanotic or cool, clammy skin, a weak or rapid pulse, rapid or shallow breathing, restlessness, anxiety, or mental dullness. Nausea and vomiting can also be present in shock states. High blood pressure is now anything that is greater than 120/80 is normal. Pre-hypertension is systolic of 120 to 139, although they're starting to move that needle down a little bit and saying people with a blood pressure of 130 systolic may actually have hypertension. And hypertension is diagnosed with a systolic blood pressure of greater than 140/90. So lowering the blood pressure with antihypertensive medication by 4 or 5 millimeters of mercury reduces the rate of stroke by about 40% and coronary artery disease by at least 16%. So not surprisingly, the presence of other risk factors will also affect these decisions, like therapeutic lifestyle changes. Ones of proven benefit have shown statistic significance and clinical importance for beneficial effects on morbidity or mortality in the cardiovascular system. Lifestyle changes that include the identification of multiple major modifiable risk factors like high cholesterol or dyslipidemia, hypertension, smoking, obesity, physical inactivity, and diabetes reduce the risk of future cardiovascular events. And these benefits are additive for virtually all patients. Adding drugs may be necessary. So in basic, treatment is trying to get the patients to eat a healthy lifestyle. What diet they pick is still up to debate. Most experts will say a Mediterranean diet is probably best. There are some people who will advocate veganism or total vegetarianism, but adding at least 30 minutes of exercise a day will also help lower blood pressure. This is an algorithm. You don't really have to be responsible for it, but this is something that the primary care provider or the cardiologist or the internist will start deciding on how to lower and add agents such as a diuretic, ACE inhibitors, beta blockers, calcium channel blockers. Beta blocker is also used to treat angina. Beta blocker refers to the ability to block the beta cells, which will decrease the heart rate. Angiotensin converting enzyme inhibitors will dilate arteries. Angiotensin II receptor blockers will also dilate arteries. MRAs or mineralocorticoid receptor agonists can also be used. And the preferred antihypertensive agents, because these improve survival in patients. So these four are the major four. that occur. All right, let's talk a little bit about chest pain classic symptoms when we're talking about acute coronary syndrome. Pressure, fullness, heaviness, squeezing pain in the center of the chest with radiation, sometimes diaphoresis, nausea, shortness of breath, and weakness. Frequency of symptoms is diaphoresis is the most frequent. Chest pain itself, only about 2/3 of patients. Nausea, about half. Shortness of breath at half, and about 1/4 will show no signs or symptoms at all. The atypical presentations are those that are found in the elderly, diabetics, and quite a few female patients. They do not present with classic symptoms. Sometimes it's just simply unusual fatigue. It could be diagnosed improperly as depression. Onset of shortness of breath, nauseous or dizziness, belching, burping, or indigestion, palpitations or a new dysrhythmia, and pain only in the jaw, neck, back, or arm. That is not classically distributed. Sometimes an anginal equivalent could be something as simple as a toothache. So all chest pain is considered to be an acute myocardial infarction until proven otherwise. So in the emergency department, anyone complaining of chest pain, young or old, usually gets an EKG, blood work, and a workup. Angina pectoris is a classic chest pain caused when heart tissue does not get enough oxygen for a brief period of time. Typically, it's crushing or squeezing in the onset with the 3 E's of exercise, eating, and emotion. And it usually resolves with rests or medications like nitroglycerin if it is stable. It may be difficult to diagnose from an acute MI. Insufficient blood flow with plaque in the coronary arteries will slow down blood flow, and that insufficient blood flow will lead to heart pain or angina. The term acute coronary syndrome is used to describe the range of conditions from unstable angina, meaning angina that does not get better with rest and nitroglycerin, to an acute myocardial infarction. That can be a STEMI or a non-STEMI. Signs and symptoms usually caused by acute myocardial ischemia. The signs and symptoms of acute coronary syndrome are similar to those of angina: shortness of breath, signs of inadequate perfusion, chest pain or pressure or discomfort, nausea, weakness, syncope, and sometimes a new dysrhythmia. The spectrum of clinical conditions, acute coronary syndrome, as I said, goes all the way from unstable angina to an MI, and it's characterized by common pathophysiology of a disruptive plaque.
Acute coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranges from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary arteries induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing. This exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrin, begin to form an arterial platelet-rich clot. This narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through two pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Okay, so what's the treatment of acute coronary syndrome? Very often, they're similar. If you have a STEMI, that's an ST elevation MI, that's positive EKG changes. And sometimes you have what's called a non-STEMI, which can only be determined after blood work is determined. You might have an EKG that's not diagnostic. And we do blood work that shows that there is troponin in the bloodstream and injured tissue. So if we have a STEMI, we get antiplatelet and anticoagulant therapy on board. We give either thrombolytics if we have less than 60 minutes to get to a cath lab, or we send them to the cath lab, that's PCI, and or CABG, coronary artery bypass graft. You know, that's a graft on their heart. With unstable STEMI, it's the same thing. And in general, both patients will wind up in this long-term medical management. Whether they get a PCI or a CABG, they'll still be put on statins, beta blockers, etc. The vascular disease, as we talked about, is the atherosclerosis, and that's the lipid in the cell membranes of the wall of the heart coronary arteries. And this little thrombosis that we talked about is what causes the narrowing and the chest pain. So we can get plaque rupture that causes platelet adhesion and a thrombus formation. It should be noted that these events are the same in MI, unstable angina, stroke, and any peripheral artery disease. Platelet cascade, what happens is platelets are exposed to the lipid core. A number of factors are released, and that causes fibrinogen to form and the clot to solidify. And before you know it, the walls of the coronary arteries are closed off. These are also other things that are produced by that. All of these information, nitric acid and all this is in the clotting mechanism.
Woohoo! Look at that blubber fly!
So here's what happens when a plaque ruptures. You have a fibrous cap that's on top of the plaque, and it's now exposed to the lipid core. A few platelets begin to adhere, and then the signal is sent to the other platelets that it's time to form a clot. Before you know it, all the platelets will aggregate, and all of them will get together, and now essentially this vessel is occluded, and to top off the cake here, fibrin will start to adhere, and that clot is solidified. And this is typically what you're going to see in a STEMI or a heart attack. Current medical management for STEMIs and non-STEMIs are oxygen. We do keep oxygen off if a patient has a saturation of 94% or more. Nitroglycerin, beta blockers, ACE inhibitors, antiplatelets such as aspirin, or in the hospital we might give heparin, and then we might start anticoagulant therapy such as warfarin, or we might start Plavix or any number of things like Xarelto or Eliquis. And then maintenance therapy, people will be on antiplatelet therapy, most likely Eliquis or Xarelto, beta blockers or calcium channel blockers to keep the heart rate down, lipid lowering agents, and ACE inhibitors if they have any form of heart failure. What happens as we watch the EKG during the acute coronary syndrome? We've gone over this before. We have an upstroke T wave, and then the first sign of ischemia will flip that T wave, and then it'll go down, and then it goes further down, and before you know it, we get into an injury pattern that we recognize as a fireman's hat or a STEMI, and before you know it, then we start forming Q waves as we head towards infarction. We have infarct regions that we talked about in the past in our EKG lecture, V2, V3, V4, supplied by the left anterior descending, inferior lead supplied by the right coronary artery, and lateral lead supplied by the left anterior descending or circumflex artery. Septal, V1, V2, and posterior, which is not shown, but usually a big ST depression in V1 and V2. These are infarct regions that we talked about: lateral, high lateral, lateral, septal changes, anterior and inferior, 2, 3, and AVF. Keep in mind that the two regions that talk to one another are the lateral region and the inferior region. So if the lateral region has ST elevation, as shown here, you will probably have reciprocal ST depression in your inferior leads. Or if you have an inferior ST elevation, you will most likely get reciprocal ST depression in your lateral leads. So lateral and inferior regions talk to one another. All right, moving off of acute coronary syndrome to congestive heart failure. A healthy heart has thick walls with good circulation. And a congested heart, you'll see congestive heart failure, that wall thins over time. And you can see how thin the wall becomes. And this heart is dilated, it's larger, and it's just not able to pump as well. Keep in mind that coronary artery disease and a healthy heart all has to do with the pump. And if the pump is in good shape, the heart will be as well. If the pump is in bad shape, you're not going to get the circulation that you need.
Hello and welcome to Healthy Nation. I'm Dr. Holly Atkins. The heart is a complex vital organ. At its simplest, it's a pump we can't live without. Each day, it moves over 6,000 quarts of blood around your body. And like all pumps, it can run into problems and eventually fail. This is called heart failure, but it doesn't actually mean that the heart has stopped entirely. After a lifetime of strenuous work, a failing heart is simply no longer strong enough to keep up with the demands of the body. The heart is an amazing organ. Each day, it beats nearly 100,000 times to provide our bodies with a steady flow of blood. When the heart pumps, its left and right sides contract or squeeze in unison. The left side of the heart pumps blood to the body, while the right side pumps blood to the lungs. Let's take a closer look at how the heart typically functions. The heart's main pumping chamber, the left ventricle, is located on the left side of the heart. The left ventricle pumps blood to the body, delivering nutrients and oxygen to all of our organs. After reaching the smallest of blood vessels in our bodies, called capillaries, and delivering its cargo of oxygen and nutrients, it returns to the right side of the heart. The right ventricle pumps this blood to the lungs, where it picks up more oxygen and gets rid of carbon dioxide. The blood then returns to the left side of the heart to to begin this cycle all over again. Heart failure is usually a chronic progressive condition that causes the heart to weaken. So either it isn't strong enough to pump enough oxygen-rich blood to the body, or it doesn't fill with enough blood. Heart failure can affect the left, right, or both sides of the heart. Left-sided heart failure is the most common, and there are two types. In systolic heart failure, the left ventricle of the heart cannot contract with enough force to push adequate blood into circulation. In diastolic heart failure, the left ventricle loses its ability to relax, so it can't fill with sufficient blood in between heartbeats. Heart failure can also affect the right side of the heart. When this occurs, the right ventricle loses its pumping function, leading to excess fluid accumulation in the body. Right-sided failure often develops after failure has started in the left side of the heart.
Okay, so heart failure itself has to do with two basic concepts. Preload is the volume of blood in the ventricles at the end of diastole, and it's increased in hypervolemia and regurgitation of cardiac valves and heart failure. Afterload is the right side of the heart. Resistance in the left ventricle, left side of the heart, overcome the resistance that it has to overcome to circulate the blood. It's increased in hypertension and vasoconstriction. Ejection fraction is how much a heart ejects each cycle. It's the amount of blood pumped out of the ventricle divided by the total amount of blood in the ventricle. It's, of course, not all of the blood leaves, and a good healthy heart has an ejection fraction of approximately 60 to 65%. Some heart failure patients only have an ejection fraction of, say, 25%. So heart failure, it's a common clinical condition resulting from any structural or functional disorder that impairs the ability of the ventricle to fill or eject blood. And heart failure may be caused by diseases of the myocardium, pericardium, endocardium, heart valves, vessels, or metabolic disorders. Hypertension is the primary cause of heart failure in many patients. In addition, hypertension imposes an increased hemodynamic load on the failing ventricle in patients with established heart failure due to any etiology. And the goals of therapy are to control the blood pressure and to reduce the left ventricular afterload. By doing that, you'll improve the cardiac function and decreasing the progression of the cardiac disease. Additional treatment is to treat kidneys, treat ischemic heart disease by lowering lipids, sometimes a bypass graft with angioplasty or bypass surgery can reestablish a good healthy heart, replacing bad valves, treating supraventricular tachycardias, particularly atrial fibrillation, by slowing down the heart rate, ventricular arrhythmias, sometimes putting in a pacemaker, and treating the ventricle itself with sometimes you have to put an implantable defibrillator in. Treating the blood by thinning it to prevent thromboembolism. If they're kidney patients, they might have significant anemia, and you might need to put them on building medicines to build up their cardiac and blood account and how much blood they have to prevent anemia. If they have a sleep disorder, they might need CPAP or breathing. Getting rid of the alcohol, getting rid of the smoking, restricting the salt to 2 grams a day, restricting fluids so that they don't build that fluid up on the pulmonary side of their heart and avoiding obesity by losing weight and doing exercise. Heart failure is a condition resulting from a damaged or weak heart, as we showed you, and it can be caused by the number of things that we talked about, MIs or chronic high blood pressure. Left-sided heart failure, back up in the lungs, you wind up with pulmonary edema and shortness of breath, accessory muscle use, and they have rails on auscultation. They're going to have difficulty breathing, cyanosis. And your right-sided heart failure is the one that's going to have a ankle edema, ascites, or a swollen liver, the distended neck veins. Body edema all over is called anasarca. It's pretty profound when you see it. You touch and put your finger everywhere, and if you've ever touched somebody who had pitting ankle edema, you push in and it's slow to rise back. Anasarca is pretty pronounced because you touch way up here in the bicep or in the pectoral region, and you can see the edema coming slowly filling back. Some people who need a heart transplant will get, for severe heart failure, they're going to get a assist mode in their heart. Sometimes these people get this and there's a battery, you're going to be called, and these people usually have a number that you can call directly to the medical school or the heart surgeon if there's problems. You just have to read what this machine here is telling you, and the nurse over the phone will tell you what to do. It's supplied by 2 batteries, and these people are usually awaiting some form of a heart transplant. And this is what they look like. Dilated cardiomyopathy is somewhat like congestive heart failure, where a normal heart is dilated and you have a dilated ventricle, and they're going to have some signs and symptoms of heart failure, which can lead to shock. There's hemorrhagic shock, cardiogenic shock, septic shock, and anaphylactic shock. And cardiogenic shock is the one that we would be worried about for heart disease. What is shock? Shock is not enough blood or oxygen to the vital organs to operate correctly. Cardiogenic shock, the heart lacks the power to force the blood through the circulatory system, and it's brought on when at least 40% of the left ventricle is infarcted or infected, affected, not infected. And the onset may be immediate or may not be apparent for 24 hours. So if somebody has a heart attack that's not treated and they infarct a good percentage of their left ventricle, you can wind up in cardiogenic shock. Signs and symptoms are similar to any shock state: altered level of consciousness, rapid, shallow breathing, restlessness or anxiety, pale, cool skin, tachycardia with sometimes with dysrhythmia, and low blood pressure or hypotension. Cardiogenic shock implies that the source of the patient's clinical status is from a disease process that originates in the heart itself. It may be similar to other forms of shock, so you may not know if this person's in cardiogenic shock or if they're in septic shock or hypovolemic shock. Treatment is aimed at recognizing and treating the cause of the shock. Causes of cardiogenic shock could be an MI or cardiac rupture, valvular disease or trauma, heart failure, which is so severe that you get pulmonary edema, cardiac toxins or poisons, and cardiac tamponade. The treatment aimed at ABCs, oxygen, IV, and small aliquots of fluid so you don't overload them. Monitor the patient as best as possible. try and diagnose and figure out what's going on, and you may need to use suppressors such as dopamine, and they're probably going to wind up going to either surgery or the ICU. A few fatal dysrhythmias.
The most common form of sustained cardiac arrhythmia is called atrial fibrillation, a fast, irregular, twitching heartbeat caused by a breakdown in the heart's natural pacemaker. The condition can cause the blood flow in the heart to slow down or even to become stagnant and pool, particularly in the left atrium. Here, the stasis facilitates the formation of a large clot with a structure and composition similar to those responsible for deep vein thrombosis and pulmonary embolism. This venous-type clot is made up mainly of red blood cells and held loosely together by a fibrin mesh. Such an unstable clot can break up or become dislodged. The entire clot, or parts of it, then travel with the bloodstream through the aorta and reach the brain. As the clot, or fragment of clot, moves along finer and finer cerebral vessels, it will eventually cause a blockage, resulting in an ischemic stroke. In patients with AF, strokes are generally more severe and often have fatal outcomes due to the size of the clots formed in the left atrium. Larger clots eventually block larger blood vessels in the brain. Both the clot formation in the heart and the subsequent stroke share the same underlying cause: inappropriately triggered blood coagulation, a major threat to the affected patient's health.
Okay. So when a ventricular fibrillation, of course, deadly, the ventricle is simply quivering and not squeezing at all. There's no pulse, no blood flow. It's a totally disorganized electrical activity in the heart, and the only key treatment is early defibrillation. VTAC, of course, ventricle is beating so fast, it's not pumping blood at all. It has a very limited diastolic period, and it doesn't allow the ventricles to fill enough to provide adequate cardiac output. And it can progress to VFib if not treated early. It may or may not have a pulse, but usually when we see this rhythm, electricity is the only cure, and defibrillation is the best way to go. There is a stable VTAC pathway where we can try medications, but very often we have to go to defib. And of course, asystole is the total absence of any electrical activity of the heart. There's a very low chance of recovery. An AED will not allow for defibrillation because there's no organized electrical rhythm. You have to perform CPR until advanced care arrives, and if you are advanced care, you have to go through your asystole pathway, which is essentially epinephrine at this point. PEA is the heart's electrical system is firing in an organized rhythm, but the myocardium is not responding. Very often PEA is a very low 30 or 40 pulse. I mean, there's no pulse, but a heart rate. No response to the muscle means no pulse, therefore no circulation. And any rhythm seen on the monitor that has no pulse is considered to be PEA. No fibrillation is good in this case, and usually it's epi and your H's you're trying to figure out. Signs and symptoms of cardiac compromise, we've kind of gone over this, is squeezing, profuse sweating, pale skin, shortness of breath, anxiety, feeling of impending doom. So if a patient tells you that they're going to die, I would say believe them, because they often try to. Abnormal pulses, epigastric pain, nausea, or vomiting. Cardiac tamponade happens when there's some type of trauma to the heart, There might be a pericardial effusion, and it could worsen. And the pericardial sac that surrounds the heart gets filled with blood, and you have signs of shock, and you have decreased pulse pressures. And that usually only responds to somebody sticking a needle in this area and draining it. Okay. Pericarditis is an infection of the heart where the pericardium is affected. It's usually in younger patients after a viral illness. It's usually a sharp discomfort, and it gets a little bit different with breathing and movement. These patients usually feel better sitting up and leaning forward. And they have ST elevation that is across the entire pericardium. All right, so in 50 minutes, we talked about an enormous amount of cardiac problems that you can see in the field. If there's any questions, I'll take them now. No questions?
It looks like we have one in the chat that came up. Cardiac toxins, poisons cause cardio shock. Does the heart release toxins itself, or if a patient somehow consumes, is exposed to a toxin poison that causes the shock?
Well, all right, so I'm guessing the question is about cardiac poisons. Cardiac poisons could be any medication that they normally take, too many beta blockers, for example, or it could be too much digoxin, for example, if they have atrial fibrillation and they're on dig. Cardiac poisons are also something simple like too much potassium or calcium or magnesium, which are usually in very, very correct amounts in the body. But for some reason, if there is a flu and nausea and vomiting, the potassium can go way up or way down, or the sodium may go down. So cardiac poisons can be actual poisons themselves, or a hyper concentration of their normal medications.
Perfect. I'm just curious, Doc, are you starting to see any trending in terms of MIs and some of these other complications going down in age into the pediatric population at all? I mean, it seems like more and more of the, we have a lot of folks that the youngest that we take at our clinic is 18, but we see a lot more obesity at that level with other complications associated with it. I'm just wondering if you're noticing anything in your practice around that.
Thankfully not. Most myocardial infarctions, I've had them as low as 35 years old, but most of the time they happen in the mid 40s to the mid 60s. That's the majority of the time. Thankfully, I haven't seen, usually there's some kind of secondary problem going on in a pediatric population. The body is pretty amazing. It'll allow you to be obese to your mid-20s before it really starts to compound upon your heart, unless you have some intrinsic disease that you're born with. And the majority of the patients, even though they may be obese, don't yet have heart disease. But most of the time, young obese patients usually turn it around and lose weight over time when they enter, high school or college or something like that.
And with those younger patients in their 30s, do you notice any different symptoms, or are the findings pretty consistent with?
No, those are usually pretty classic symptoms.
Okay.
Chest pain, shortness of breath, etc. I'm going to ask a question out there. Is Carmela Birch online?
Yeah, she was the one that posted in the chat.
Oh.
It looks like she has.
I just want to know if that's Stonehenge she's at. Where?
It looks like maybe the Taj Mahal.
No, where are those pictures? Some type of stones.
Yeah.
All right.
Looks like India. That's what she typed. So guessing
yeah.
Taj Mahal.
Okay.
Outside a temple. Huh.
Okay.
Hey, Doc, are you guys planning on doing anything around coronavirus for one of the MD roundtables? I'm sure it's a hot topic and you're probably sick of discussing it, but out here in Colorado, we've got 160 cases.
Right now, it's such a mess, in all honesty, that here in Oregon, they've closed all our bars. They've suspended all our activities. I'm heading out of state on vacation, and I'm not telling anybody where I'm going. So I don't have any plans to do a coronavirus. It might be interesting to talk about in the future once it plays out a little bit. But right now, it seems to be nothing but a lot of fear. We should prepare for it. We should, protect ourselves. We don't want to get sick. And simply, mask the patient and use good, PPE protection and go from there.
Great. Well, have a great vacation.
All right. Thanks. All right, everybody. I'm going to, I guess, wrap this up. I don't know if, let me see if I can't see if.
I think there's just 4 of us, 3
Dean
students.
is still on? No? Okay. All right. So I'm going to just end the recording and leave it there.
Perfect. Thank you very much.
All right. Thank you.
Thank you. Appreciate it. Have a good night.
Bye-bye.